Order. We'll call this meeting to order. This is the Standing Committee on Health, and I'm Trevor Boudreau, the MLA for Richmond and Chair of the committee. Today we will hear from witnesses regarding the implementation of additional mental health and addiction support. I'd ask everyone to make sure that your phone is on silent. And what we'll do first is we'll have an introduction of committee members. So I'll ask them to introduce themselves, stating their name and constituency, starting with my left, and MLA Smith.
Thank you, Mr. Chair. My name is Kent Smith. I'm the MLA for the Eastern Shore.
Good afternoon, everyone. My name is Chris Palmer, MLA for Kings West.
Good afternoon. I'm John White. I'm the MLA for Glace Bay and Dominion.
Good afternoon and welcome. I'm Tom Taggart, MLA for Colchester North.
I'm Gary Burrow, the MLA for Halifax Chebucto. Hi.
Good afternoon, Laura Lee Nichols, the MLA for Cole Harbour Dartmouth.
Hi everyone, I'm Brayden Clark, MLA for Bedford South.
Thank you all, and for the purposes of Hansard, I'll also recognize the presence of Legislative Counsel Gordon Hebb and Legislative Committee Clerk Judy Kavanaugh. As I mentioned before, the topic for today is implementation of additional mental health and addiction supports, and we have a number of witnesses here with us today. So I'd like to welcome all of you here, and I'll actually get you all to introduce yourselves first, starting with Ms. Brennan on my left.
Good afternoon, Maureen Brennan, Director, Mental Health and Addictions at the IWK.
Ms. Pulsifer.
Good afternoon, Dana Pulsifer, Senior Director for Mental Health and Addictions at NS Health.
Ms. Vezina.
Good afternoon, Francine Vezina, Executive Director with the Office of Addictions and Mental Health.
Oh, Ms. Trott.
Oh, can't see the red. Kathleen Trott, Associate Deputy Minister of Office of Addictions and Mental Health.
Ms. Cunningham.
Starr Cunningham, President and CEO of the Mental Health Foundation of Nova Scotia.
And Ms. Nichols.
Karn Nichols, Executive Director of the Canadian Mental Health Association, Nova Scotia Division.
Thank you all, and I do believe that we have a number of witnesses who have opening remarks, and so at this time we'll have those opening remarks, and then we'll move into the Q&A section of the committee meeting. So I'll start with ADM Trott, if you would like to start with your opening remarks.
Perfect. Thank you, Mr. Chair, and thank you for the opportunity to join you here today to talk about and answer the committee questions on the work we're doing in addictions and mental health in the province. As I introduce myself, Kathleen Trott, Associate Deputy Minister responsible for the Office of Addictions and Mental Health. And I'm here to talk about the progress we're making towards universal mental health and addictions care. As you can see, I have a few people with me today to help answer questions that you've just met with Francine Vezina on my team and in partnership with Dan Pulsifer and Maureen Brennan. We're a small team at the Office of Addictions and Mental Health, but we have a big mandate to create a universal mental health and addiction system of care. When we talk about universal mental health and addictions care, we're talking about finding solutions so more people can access the care and support they need. We're talking about services and service delivery models tailored to the needs of our population. It's about addressing gaps at every point along the continuum of care and making it easier to move between services as needs change. The goal is a system where every Nova Scotian has access to the services and supports they need when they need it. I find it helpful to think about the work in three categories. The first is our traditional healthcare system, where we're expanding to reach more people, adding new services, making the ones we have better. For some examples, our new day hospitals in Halifax and Sydney, 5 new recovery support centres in Dartmouth, New Glasgow, Middleton, Lunenburg, and Evanston, the expansion of our new preschool autism services, the integrated youth service expansion implementation, new clinicians we've hired, including 6 new psychiatrists in Cape Breton, and the connections we've made between rural EDs and mental health and addictions clinicians all over the province, and so much more. The second category is about tapping into the capacity we know exists in Nova Scotia already, whether that's psychologists and social workers in private practice, community-based organizations like the Canadian Mental Health Association and the Mental Health Foundation of Nova Scotia, and of course our colleagues and universities, colleges and universities. For example, the pilot project we announced yesterday that's helping address the wait list for autism and ADHD diagnostic assessment. We've made increased investments in community-based organizations so they can do more of what they already do so well, while at the same time creating a community wellness framework to guide and focus this work going forward. We've added new services people can use virtually, like Access Wellness, Peer Support, and PSPNet, which is a therapy program for first responders, and a suite of new e-mental health tools like Tranquility and Together All. The third category of work on universal mental health care is about integration, bringing all these pieces together: the formal healthcare system, the online tools, the pilot projects, the community-based services on a solid foundation to make it easier for people to get the right care to match their need. We currently have a central intake line where people can call and self-refer. They don't need a referral from a primary care provider. They can call our toll-free number and speak to a clinician who will do an assessment over the phone and get them connected to the right program or service provider, the right care. That's important. When it comes to mental health, it isn't always about inpatient psychiatric services. In fact, that kind of care is needed by only a small percentage of people. There are so many other options. So maybe it's clinical care through NSHR IWK, ongoing support from a registered psychologist, or counseling from a registered social worker. Maybe it's peer support. Maybe it's a service offered by a community-based organization just a few minutes down the road from your house. That's what universal mental health and addictions care is all about. And the goal is the right service from the right provider at the right time and available to everyone. Thank you.
Thank you, ADM Trott. Ms. Cunningham?
Thank you very much, and I'm very happy to be here today representing the Mental Health Foundation of Nova Scotia. So the Mental Health Foundation is a charity that exists to increase financial support to community initiatives throughout Nova Scotia while providing hope, that's our key word, and eradicating the stigma surrounding mental illness and addiction. Our vision is simply to see Nova Scotians who are living with mental illness and addiction thriving in our communities, not surviving, thriving, and not in our hospitals, but in our communities. We do that by providing grants. We have community grants, Nova Scotia Health Mental Health and Addiction grants, named grants, mental health literacy grants, and episodic grants. In 2022-23, the Mental Health Foundation of Nova Scotia approved 241 grants totaling more than $3 million. Most recently, we closed our application period for second-round community grants. We received 137 applications touching every area of the province. Those applications are now being reviewed and scored by our Volunteer Grants Selection Committee. This committee is made up of 7 individuals who represent our Board of Trustees, Nova Scotia Health Mental Health and Addiction, Black, Indigenous, and people of color, and 2 LGBTQIA+ communities. Later this month, the scores will be tallied, decisions discussed, and all applicants will be notified of their decisions. Our goal is to get the funding in the hands of the successful organizations as soon as we possibly can, so that their mental health programming can get underway. Now, the programs that we fund really range. So we fund everything from peer support, one-on-one counseling, mental health education, community engagement, music therapy, art therapy, recreation therapy, employment support, sexual health support, trauma support, and more. And as I'm sure you can appreciate, these additional mental health and addiction supports will have a significant and measurable impact in every area of Nova Scotia. They will make our community stronger, more resilient. They will raise mental health literacy, change lives, and in many cases, save lives. We are not the providers of the programs and services. We are the enablers. So the Mental Health Foundation of Nova Scotia provides the money. So simply put, we do the fundraising so that people and organizations who have the skills to help, people like Karn and her team at CMHA Nova Scotia, can do what they do best, and that is support the mental health and addiction needs of Nova Scotians. The Mental Health Foundation of Nova Scotia has the unique opportunity to hear directly from organizations and individuals who are on the ground in their communities, the people who are doing the work and detecting the gaps and identifying priorities. The foundation creates hope and help for improved mental health. We work with individual donors, corporate funders, other foundations, government, including the Office of Addictions and Mental Health, and community event volunteers to make it more efficient and more effective for mental health and addictions experts to provide their services and programs. We are incredibly proud of the difference we make in the lives of Nova Scotians by funding mental health and addiction initiatives in our communities. We strive each day to change the way people think about mental wellness, mental illness, and addiction. Thank you.
Thank you, Ms. Cunningham. Ms. Nichols.
Thank you so much for the opportunity to speak with all of you today. I'm deeply appreciative of the chance to share a bit about who we are, how our work impacts Nova Scotians, and how we can work together to serve the mental health and well-being of folks and communities all across this province. I'm Karn Nichols, and I'm the Executive Director of the Canadian Mental Health Association, the Nova Scotia Division. You may not know this, but CMHA Nova Scotia is part of the most extensive community-based mental health network across Canada. We are a federated charity, which means we're a collective of organizations that are bound together by brand and by mission. Together, we identify and respond to Canada's most pressing mental health priorities. At the national level, we push for nationwide system and policy change, and at the community level, millions of people in Canada rely on our extensive grassroots presence. There are 330 CMHA divisions and branches across the country, and these branches and divisions employ 7,000 staff and are supported by more than 11,000 members and volunteers. We've been active in communities across Canada for over 100 years. In our combined Nova Scotia operation, which includes the division, which is what I'm responsible for, and our branches, we employ about 55 staff and 72 volunteers. I begin by sharing this information because I found that CMHA brand is well known, yet there's a lot of confusion about what we actually do in community. Just ask Starr. It's not unusual for the general public, and in particular our funders, to be deeply confused at the respective missions and mandate of CMHA versus Mental Health Foundation. So maybe we have clarity today. In Nova Scotia, we're a small but mighty team supporting over 10,000 individuals over the past couple of years in communities around the province. With our branches in Halifax, Dartmouth, Colchester, East Hants, and Southwest Nova, we deliver safe, inclusive, evidence-based programming, training, and support services that address the social determinants of health, including safe, affordable housing, sustainable employment, food security, access to education, and most importantly, human connection. Our vision is a Canada and a Nova Scotia where mental health is a universal human right. At the division level, we have 3 strategic pillars. They are advocacy, education, and resource navigation. At CMHA Nova Scotia, we are responsible for working in collaboration with our government, our community allies, and partners to align and strategically deliver relevant services and programs across the province. If you think about our mental health continuum, where our mental health is measured in terms of thriving at one end, where we're sleeping well, we're eating well, where we feel normal, to surviving, then struggling, and then to crises, the center of gravity for our work is building capacity in our communities so that we all have the tools to thrive and survive. We operate in the sort of tier 1, tier 2 space of the step care model. By doing this, we support the healthcare system to keep people out of hospitals, out of emergency rooms, both before mental illness can occur and after the crisis has passed. So what does this look like in the community in terms of program delivery and direct service delivery? Under program delivery, we have a core operation of education and mental health literacy. So in addition to things like assist and safe talk for addressing suicide prevention, we have courses that are evidence-based and such as changing minds, living life to the full, rebuilding our resilience, stress management, community suicide awareness, mental health in the workplace. We also custom build as required in community. As a backbone to that, we have what we call a recovery college, which is free programming. It's a virtual learning center that anyone can access, free workshops to learn, gain new skills, and connect with others in their community. They're developed by subject matter experts with lived experience in collaboration with individuals who have experience in developing the programs. Topics in our workshops range from understanding anxiety to self-care and anything beyond that. As mentioned previously, we do a lot under what we call CAST, which is Communities Addressing Suicide Together. And we know that suicide is a permanent response, which is often part of a passing struggle, and that's where intervention is really critical. We play a role in prevention and intervention through providing subsidized training and assist resilient minds and safe talk across the province. These are often subsidized by our friends at Starr's organization so that we can actually make it available to many more people. Peer support has been mentioned, and that's a piece of what we do across the province. And then the other piece that we are currently getting funding through the Office of Addictions and Mental Health, which we're quite excited about, is 2 pilot projects, one in Southwest Nova and one in Cape Breton. We're being intentional about 2 things. One is not reinventing the wheel and creating a framework of support for the informal mental health systems that already exist in these communities. The barbers, the pharmacists, the church leaders, the Rotary Club members are all part of our mental health system when you think about it. And and we are working with these communities to design programs to support them in this important work and provide them with the tools so that our social net in rural Nova Scotia is strengthened. Our approach will also allow us to innovate these programs with a decolonized lens, giving voice to those who have been traditionally underserved, underheard, and underrepresented. So in the direct service piece of what we do, we have a couple of programs. One is Project Hope, which is housing outreach and peer empowerment. And throughout the valley, we work to reduce homelessness and working with those who are living with mental illness and struggling with mental health. We have At Work, which is addressing those who are unemployed due to mental illness or living with mental health issues. We have a variety of social clubs across our branches and the province, community and outreach work, which is based primarily in Colchester and East Hants, and independent living support as well, which houses 40 individuals in independent living situations. Finally, we have a program called Bounce Back, which is a national program that is available to folks in Nova Scotia. It's a free skill building program that's provided through us by CMHA National. It's designed to support adults and youth 15 plus manage low mood, mild to moderate depression, anxiety, stress, or worry. They work with a coach and a guidebook, and it's based on the sort of CBT principles. CMHA is a non-for-profit charitable organization that delivers these mental health programs and services to anyone who needs them. Funding from federal and provincial grants and donations allow us to keep most of our programs free or low barrier. I came to this organization just over 2 years ago, and I learned quickly that our current mental health system is a complex web, that in any one day we could be wrestling with housing a young pregnant mother in Kentville, developing programs of caregivers for the 2 SLGBTQIA+ communities in rural Nova Scotia, working with folks from Portapique to develop a story trail to nurture community resilience, reporting to funders, sitting on panels discussing mental health in the workplace, building relationships with the informal systems in our First Nations communities, meeting with domestic abuse survivors who are finding agency and leading their own peer group in North Sydney, doing the same with newcomers in Yarmouth and advocating for universal mental health, and coordinating the board while managing the day-to-day operations of a growing organization. This sector is known for being collaborative, yet sometimes we struggle to coordinate our efforts in service of our communities. We're more than our programming. We believe that we're an integral part of the mental health care continuum. We're committed to continuing to advocate for the social determinants of health, reducing stigma, mental health literacy, and mental health parity, universal mental health care. However, there's no doubt that there's an increasing demand on charitable services that are outpacing the sector's ability to meet that demand, and with less available to cover charitable needs, our social fabric starts to feel not so secure. We believe the solutions to many of our issues are with the resources that are already in place. But in order to leverage these solutions effectively, we need to stabilize the operations, that we can focus on coordination and strengthening our social fabric by delivering our services so people who need it, to the people who need it the most. I think we all recognize that as a province, it's important to continue to invest in community-based mental health initiatives. By investing in the work of CMHA and all of our sister organizations across the province, we're actually supporting the healthcare to keep the people out of the hospitals, out of the emergency rooms, both before the mental illness can occur and after the crisis has passed. So to this committee, I'm so grateful for the opportunity, and I know I speak on behalf of all my CMHA social impact sector colleagues across the province when I say we look forward to working alongside everyone in this room to serve the mental health needs of all Nova Scotians.
Thank you, Ms. Nichols. And now we're on to the question and answer period of the meeting. So each caucus gets a first 20 minutes of questioning, and I think I mentioned to some of you it's kind of a hard stop at that 20 minutes. So I apologize in advance if I do cut you off. And then, depending on what time we have left after those 20 minutes, each caucus will get an additional 8 to 10 minutes probably to ask questions. We're going to try to wrap up questioning somewhere between 2:45 and 2:50, and then you have an opportunity to speak, and then we go on to some committee business. So with that being said, the Liberal caucus will be first with the 20 minutes, and I see Mr. Clark pointing to Ms. Nichols. So Ms. Nichols, you have the floor.
Thank you. And my name is spelled this way, not that way. Everyone always puts the H and the S at the end, so nice to have another nickel in the house. I just want to thank you for your presentation, and full disclosure, I'm sitting here with some anxiety because I have generalized anxiety disorder. So yeah, and went into politics, so that's an interesting mix. But that being said, you spoke, Karn, about the lived experience and hearing from people. But I hear from people from mental health issues that they don't feel that they have an opportunity to have their stories heard, and that they wish that they could provide it to somebody so that you would understand what they went through. I actually had a psychiatrist once that told me I should become a psychiatrist because I know what it's like to have lived through an episode, and he didn't. And at the same time said, oh, you're depressed. Did you think of killing yourself? So when all these things happen, you're kind of like, you don't tell that to somebody with anxiety, in my opinion, because it's like, oh, is that a possibility? And so therefore, I was struck with Dr. Sherry's article in today's paper in that regard, about suicide rates are increasing across the province, and it cannot be attributed to just population growth. In 2020, the suicide rate dropped to 12.3 per 100,000, but quickly jumped to 14.8 in 21, and then 15.5 in 22. And the big question is why? So I guess as a lead up to my question, I would like to ask anyone who wants to answer his question as to why there's still an increase. And I know that isolation during the pandemic played a key role. I'm not sure if there's data out there that sort of shows what the pandemic actually resulted in with regards to everyone's mental health. But every day they talk about anxiety. It's health anxiety. It's a thing. And now we have climate anxiety. And so there seems to be many terms being added to the word of anxiety, but it's still anxiety. And I don't know, like, at the end of the day, where you tell these people, or how you actually, when you listen to them, how do you determine whether they're, what was your chart? Whether they're thriving, surviving, or in crisis. So those are kind of my questions at this point.
So MLA Nichols, I'll ask you to table the document that you have there, and I will open it up to the floor. I see ADM Trott first, and then...
I think I can start this, and I think there's probably some others that will want to contribute to, because we read that same article, and we're looking at the numbers as well, and really any loss or injury from suicide is a tragedy and not what we want to have happen, certainly. And I think it speaks to the need for us to continue to focus on increasing access to supports for folks, not just in crisis, but across that whole continuum, which I love how we use tiers and numbers, but I love how you has spoke to the continuum. And I think that, the last few years has been very difficult for Nova Scotians, and we've seen a large increase in demand and in acuity and complexity. So it's not just that there's more with dealing with more things. So it's a challenge for sure. And I think that there's some things that we're focused on, and there's some things that we are here at the table with that we would want people to know about. So if they're getting into that situation where they're feeling like they want to end their life, that we are there for them. So I'll ask Dana Pulsifer to maybe speak about the provincial crisis line and our work around 988 that's coming, that we think will make a difference for sure. But I also think that there's some things we're doing around the men. So in the data, it shows that men of a particular age range are highest statistically. So we do have a campaign that's been developed that's coming this fall to help promote some help-seeking behavior. So just trying to build literacy, as you say, and help folks understand what they're thinking maybe is normal, and there is people that you can talk to about it, and just really trying to build that literacy and reduce that stigma and build that resiliency. And we're certainly also, I think too, for Starr and Karn, you both do work in Suicide Invest, so maybe a good opportunity for you to highlight some of that as well. But maybe over to Dana, if that's okay to talk about.
Ms. Pulsifer?
Oh, sorry.
Thank you. Thank you, Chair. Yes, I'd like to talk a little bit about our crisis line. So, we have specific access points for folks who are struggling to that degree, who are in a crisis, who may be contemplating suicide, may have suicidal ideation. Excuse me, and our crisis line is 24/7, 7 days a week, and really the goal of that person on the other end of the line is to calmly and clearly and safely kind of walk through a process with that person who is struggling at that moment, to find out what their needs are, to possibly do a safety check even, to find out what is their next step, whether they should go to the emergency department to be further assessed, whether some other supports can be provided to them, whether they have a support person with them. I think, there's several interventions and several service areas and access points that we can provide through our NSH Mental Health and Addictions program. And I would say those are really important to continue to enhance and implement and provide more access to. We also, in the central zone, have the mobile crisis unit, and I know that they're very compassionate folks who go out into the community. They do some of those wellness checks, and I think that's something that has been needed and asked for across the province. I think we try to provide different routes based on the ruralness of the rest of the province, but that crisis line, I think, is one of the first steps we continue to promote and hope that people would be able to call that line. With changing the number to 988, we're hoping that the promotion and the uptake and the remembering of the number will be really, really helpful. The actual service provision will remain the same. And I think, we get a lot of feedback from folks who call that line and find it very, very helpful. I guess I would also add, I'm very impressed and passionate, and I think we're in a place right now around that whole continuum of care that Karn was talking about, as well as, oh my goodness, just forgot your name. Starr, I knew that. And just, how mental health and mental wellness and addiction care really is across that continuum, and to even think about tackling and studying and understanding the numbers that came out yesterday is really a larger kind of plan of action, one that is needing to take place across all of the levels of care, all of the tiers, because we have to also start with those prior to being in crisis. We have to provide them the services and supports like our colleagues do in that tier 2 or the mild community-based organization areas, which we're really proud of having those community-based organizations as part of that overall system of care. And I really think, in order to answer the question of why, we need to study that more. We need to understand more around those social determinants of mental health and health. We know about the housing crisis. We know about the tenting encampments. We know that the price of housing has gone up. We know that we have more people coming into Nova Scotia and coming in with their own health and mental health issues. And while that might not be the sole reason for the increase in the numbers, all of that certainly contributes to the reality that we're in today. So I guess I would just say that I'm very hopeful, somebody used that initially, very hopeful that collaboration and partnership around working together across all of this continuum of service provision and supports and care will help kind of reduce the risk and reduce the numbers of folks who contemplate suicide.
MLA Nichols.
Thank you. And I guess my next question was just that, about data. Is there any data that exists that sort of guides all of you in your decision making? I mean, when you talk about, this government said they were going to establish universal mental health. Universal to me means it doesn't matter where I live in Canada. I will get that help and that care that I need. So what is the timeline per se on getting to that place where we all need to be for our mental health? And what is the data available now for you as to establishing a plan going forward to actually say yes? And we should be talking with federal organizations to sort of see what other provinces are doing as well?
I see Ms. Nichols' hand up. Is that okay? Or
yeah.
Ms. Nichols?
Would it be okay to refer? I have a little bit of data. It's national data, but it's from August, so it's somewhat relevant, and it speaks to some of the things that you were talking about. But I also wanted to speak about some of the things that we would do to address it in the province as well. Is that appropriate at this time?
MLA Nichols, I see your hand up.
Thank you, Chair. I would, but and at the end of the day, you're doing great work. But I would like to know from the government actually what they're doing when it comes to creating a universal health care plan.
ADM Trott.
Yeah, so we've been working very hard over the last 2 years around this very significant mandate to introduce universal access for addictions and mental health. And, we are making progress. We are seeing action happening that I'll share with you, and then we can talk about the evaluations that we're doing and where that is going to be leading us. So really our work fits into kind of 3 big categories. So I think I sort of talked about this before, but the first is within the formal health care system. And so the things that we would be doing around universal, it's really about looking at that full continuum, identifying the gaps, and finding solutions to fill the gaps. So a great example would be the new mental health day hospitals. So previously there was inpatient and then outpatient. Well, now we have an intermediate step, which allows folks who need more intensive services throughout the day to come back to the hospital and get treatments and services and all of that, but then they go home at night and are with their families. So when you it's a nice transitional out to a community organization and giving folks what they need to be successful versus staying in inpatient too long, which we know can hurt, and then or being bounced out so fast that they're struggling with that. The other pieces would be like the recovery support centers, the autism service, integrated youth service expansion, connections between rural EDs, and expertise all over the province, and hiring more clinicians. So there's been a lot of activity happening and a lot of pilots happening. And so we have some pilots underway around what we announced yesterday with clinical psychologists, the Dell Mental Health Clinic today. We've got other pieces in play around our e-mental health tools, Tranquility, and Together All. And what we're doing is looking at, as we create these pilots, we're looking at what are our indicators we're looking for, how can we learn from those, and then transform them to be either spread and scaled or tweaked because they didn't quite do what we had intended for them to do. So there is data. Like data is a key area of focus. And then the other piece would be a bigger area of data around patient outcomes, routine patient outcomes, which is we're piloting that now. But IWK has actually finished their pilot and moving forward with expansion. It's really more about actually what does the patient want to achieve and how do we help that patient achieve that, and we measure that over their treatments and get really more meaningful outcomes from success from programs.
MLA Nichols.
I would like to give the opportunity to the IWK now to speak because mental health services at the IWK will take you up to age 18. And so therefore, how does it transition back to Ms. Trott?
Ms. Brennan.
Thank you for the question. And is your question about the transition to the adult services?
Or all the above that we already discussed.
Okay. I'd like to provide comment on your first question around data. Data is very, very important to how we design our service and how we understand the need of children, youth, and adults right across Nova Scotia. Universal Mental Health has taken that data so we understand where there's gaps and where there's opportunities for us to improve. So that's embedded in our daily operations, but also in our improvement opportunities. Specifically, the evaluation of, for years, there were questions about how do we know our services are working and or effective, and how do we understand that experience or we're making a difference. And so the IWK has implemented Green Space Platform, which is a platform, electronic platform, that is set up at central intake, because we have one provincial central intake portal in which anyone can make a referral into that. A evidence-based triage happens at that point of intake, and at that point of time they're matched to the right care provider and or supports that's required. So it's really organizing our system of care, matching the right identified need with the right person at the right time. My colleagues here that do tremendous work in the community, sometimes the right care is absolutely matching them into community-based resource. Other times it's coming into our system. If they do come into the formal system of mental health and addictions, they come in through a evidence-based triage tool, then they're matched into a first appointment. At that first appointment and at intake, they're registered into the Green Space platform, to which they get a battery of measures that are collaborated by that caregiver, by the youth, and by the system that actually identify the goals for the treatment. And the evidence-based measures actually match what they want to have happen in the system. Those measures then follow them through multiple episodes of care. If they're coming in for a community-based ambulatory episode of care that might last 6 to 10 months, depending on those goals they have for service, those measures will follow them into the clinician's office, and they'll be able to, with the caregiver and the family, pull those measures out so they can understand how they're making progress or not on the care. It actually it provides real-time data for that clinician and family to see where they're making improvements, what they need to shift, where they need to focus on, and actually if the services are making a difference. When we lift that up and we cut across, we're able to tell lots from that data about our services being effective. We can actually pivot and change services when we're recognizing that there may not be as effective for that person. So we're able to quickly, in real time, make that change, maybe match a different treatment that might better suit their needs. So just giving you an example of data and how we have it now at the client facing in real time, but then also to help our program development and identifying the needs across across Nova Scotia.
MLA Nichols, you got about 1 minute and 20 seconds.
Well, I could pass it to him just to have just a quick question.
MLA Clark.
Thank you, Mr. Chair. Just a quick question for ADM Trott around the universal program, which I'm sure I speak for all of us when I say obviously we want to see that succeed. I think it's an incredible opportunity for the province, but I'm wondering, is there a timeline? Even I know these things are difficult and they're moving targets, but is there a year on the wall in the office, or is there something towards which you're working, at which point you hope to say, look, we've achieved this and we've actually established this universal program here in Nova Scotia? Is there a timeline attached to that at this point?
ADM Trott.
There's not a hard and fast timeline, but we're working very hard on all of the mandate items to make progress right across the board. Some of them are more complex than others, so like service codes are a bit more challenging, and because it involves a whole system around it, some legislation needs to be changed, all of that. But we feel...
Order.
Oh.
The Liberal time for questioning, the first 20 minutes is up. We'll now move on to the NDP Caucus. And MLA Burrell, you've got 20 minutes.
Thank you, Mr. Chair. Ms. Trott, would you like to complete your thought there just before we begin?
ADM Trott.
Sorry. Now I'll go back. So yes, many things in play. Some are more challenging. We are making progress, though, in particular areas. So some of the services that you've seen us introduce over the last couple of years, like Access Wellness as an example. So when we think of universal along that continuum, it's not just about more psychiatrists, more psychologists. It's actually about how do you create access right across so that we're meeting people where they are and what their needs are. So and hopefully not having to have folks escalate up that continuum. So Access Wellness would be a great example. It's a single session counseling therapy. It plays a role in the continuum. So for someone who needs quick access to 1 or 2 sessions of counseling, and then that's gonna really help them get on with whatever they were dealing with, then that keeps them from escalating up and needing a higher level of care. So we're really trying to create a system that does match the needs of individuals when they're ready for them or what they need, and be able to move up and down, because as we know, folks sometimes can get sicker or better, so they still have that opportunity. And then the other big piece for us, so we're adding all these services, which is great, but we also need to make it easier for people to get matched to the services. So really working together on system integration and with our partners in community-based organizations as well, because it's really that whole system that we need working together to create the universal. It's not like a one thing, it's all of these things. And so we're making investments right across the board for that.
MLA Burrell.
Yes, thank you. Just now with a week back in school, I wonder if we could turn to the question for a moment of mental health in schools. I wanted to ask the representatives from NSH and from the office about this. I'm sure you're aware that lots of concern have been expressed through the teachers' union about the inadequacy, in their view, of mental health services available in schools. And we know that there was some increased funding made available last year, but that it comes to in the hundreds, not thousands, per school. So I want to ask: are there plans to increase the amount of resources and services that are available in this critical area of mental health supports in schools, in the school system?
Ms. Vezina? Sorry, Ms. Vezina, there you go.
Thanks for the question. There have been a lot of investments that are kind of across, so I want to give you a little bit of information on what's currently available first. So we have available the Schools Plus, and there's 54 clinicians across the province right now that are already providing services in schools. There's adolescent outreach, which is available in 99 schools across the province, as well as youth health centres, and there's 72 youth health centres across the province. So there are various mental health and addiction supports already available through those structures. What I know as well is also the school, through the Department of Education and Early Childhood Development, that there's also psychological supports available through there. And so I can't speak to what they may be providing there, but what would be new and up and coming for us would be the integrated youth services as well, which will be available in communities. And that is, again, working with community-based organizations to ensure a network in communities where children and youth live, looking at high-risk youth and how to bring sort of a wraparound approach to the varying supports that they need. Because often what we see is that it's not, mental health and addictions issues don't, exist in a vacuum outside of as we mentioned earlier, the social determinants of health. And so what I might do is pass it over to Maureen, who can certainly provide a little bit more details on this integrated youth services model, which is really a national effort going on right now, and which we're pleased to be a part of.
Ms. Brennan?
Thank you. I'd like to comment on the integration of Schools Plus model with mental health and addiction services as well before I jump to the other question. It's really important that there are many partners in the space of mental health and addictions, and the school is a really important environment in which we're connecting and coordinating care. And so it's about making sure that all of the key services and supports that happen both in schools, community, and our system are connecting the dots. We have a provincial committee by which IWK, NS Health, Department of Education have a provincial aligned model by which we plan services and we look at pathways of how we can connect the dots for all youth across schools, so we can create stronger pathways, we can enhance the capacity of an integrated system. And we're continuously meeting every month to improve that provincial model, but that's been up in operation for close to over 7 years now, and so we're continuing to refine that. So that's really in response to the question around the integration. The other gap that we recognized is within the community. There's an opportunity for us to introduce integrated youth services, which is a low barrier access that provides services that can be integrated within the community in one location where we have multiple partners that can come together in a model that actually connects the dots. And what we recognize when we look at the data, many of these youth are cutting across school, they're cutting across our community organizations, they're in mental health, there are lots of organizations, wonderful organizations that are connected in the community. But what we didn't have a necessarily good grasp on is a well-connected, coordinated system by which we can come together around the youth, so the youth isn't traveling in isolation or that we're experiencing unintentional fragmentation, but a place where we can come together. Integrated youth services is that solution, where it relies upon partnerships coming through justice, education, mental health together as we come around and provide services for kids beginning at 12 up to the age of 25. What's important about this model is two things that's unique, is that it actually covers up to the age of 25, when historically our systems were siloed in that there was youth services at age 18 that you commented, and then there's adult services. This provides opportunity for us to share care, to ensure smoother transitions, and to work with one another and learn from one another about how we can be more responsive in an integrated way. The other important thing around this model is that it provides connection with national federation across Canada, where we work in partnership. You asked about provinces, so we actually have a federal Atlantic Province Federation for Integrated Youth Services. We're already working and having shared indicators, so we understand how are folks building resilience, how are our programs being responsive, and how can we learn from one another. It's deeply embedded in research and data, and so there's a huge component of research for us to understand how are our youth doing across Nova Scotia, and how are we comparing against other provinces, and how are we comparing nationally and internationally. So the federation is completely an evidence-based federation that actually gives us access to national and international data banks to actually have opportunities to improve what we do here, but learn from other countries that maybe have other solutions we haven't considered. So that we're not creating something net new, we're building off of the evidence and the lessons learned in other countries that have implemented this model. So our hope is that over the next 4 years, we will have 2 of these integrated youth services in each zone. And the other component, which is really, really important, and I should have led with, these are community-led organizations. These are not these government organizations doing too. This is really about mobilizing the community expertise to understand what their needs are, unique to that community, working with community leaders and providing them the support, the sustainability, and the resources to ensure this model can work for them. And there's key tenets that the model has to meet, but there's a level of flexibility to make it contextually relevant to that community as well. So the work is already underway. We are in the midst of an RFSQ process where prior to that there has been close to 2 months of engagement right across Nova Scotia with communities. There has been over 700 engagement emails sent out to all youth-serving organizations who might have an interest becoming a lead agency for one of these sites. And I'm happy to say that we've had over 500 people attend these engagement sessions over a 7-week period, because the goal is to really engage communities in this opportunity to help us co-design what services would look with not only the community, but with youth at the table and caregivers. So there's a real opportunity for us to not only fill a gap, but make it contextually relevant right across the province, and to give the right support. So the IWK will be providing support around that model, around the opportunity to provide information around programming, staff training, development, and those types of things, but it will be lived within the community and operate and led by the community.
MLA Burrow.
Thank you. Switching subjects, I would also like to ask those of you from the departments about the dimension of mental health relative to the report of the Mass Casualty Commission. The Commission was very critical about the inadequacy of supports that it identified, and we understand there have been response that's come about that, including this call for proposals for more community-based services that's recently closed. So I wonder if you could update us on the status of that call, and what are the kind of services that may be announced and what we might be able to look forward in the near future to hearing about.
ADM Trott.
Thank you. I'll start, but I'll pass to Dana because she's been heavily engaged at the community level around meeting with folks there and helping to design things. So yes, we've heard from that from the recommendation that the services that we put in place did not meet the needs. So we accepted that and are learning from that and how we can do better for community in the short term, in the now, but also in developing with community that longer term program of what they need. It has been very interesting to be in community and hear from community around what their perception of mental health supports are. Not always clinical, actually, and I think folks here would understand, like, sometimes it's about having a place for men to gather and share their feelings in a way that's safe and natural, or getting folks out playing pickleball, for example, like really getting community out together. And so I think our response is absolutely all on the clinical side, certainly, and I'll ask Dana to kind of speak to that piece of it, but then also we're going to be looking at more community development type investments and putting the money into the hands of community for them to lead what they think they need to help their community heal and thrive. So I guess I'll ask Dana to.
Ms. Pulsifer.
Yes, thank you for the question. Actually, this work, I would say, our approach is in line with everything that we've been talking about this afternoon, about coming together with all levels of service, care, and support. And that needs to happen across the continuum. And that's what we've been hearing through our listening and engagement sessions. So as everyone is aware, we had to bring to the table by May 1st a proposal or a program, and we needed to do that with community at center and driving it. So we've been, since that time, really engaging to hear what are the things that are required, what are the strengths of those communities, what are the supports that they are looking for. We have done many things, so I'll just maybe kind of share some of that. So we've been able to hire quite quickly into this process in mental health and addictions, 3 community outreach workers, and those folks have been kind of on the ground in the communities since, end of April, early May. We've had a mobile unit with public health, primary health care, and ourselves visit the different communities early on in May to provide healthcare services and mental wellness type services. And we had an engagement team kind of travel with that mobile unit, and again, to gather input, feedback from community members and individuals at that time, what they were experiencing, what their needs were. And that's a key part of the recommendation is really engaging community and hearing from them. And we're using that feedback to design an approach or a model of care or a program, as a recommendation terms it, for grief and bereavement services and mental wellness services that the community's needs are, and that can evolve as we learn more and as communities and individuals kind of progress through these phases of grief and recovery and wellness. Just to mention that recruitment is ongoing for a range of frontline and clinical positions. That will include a grief expert lead in the area, and that focus will be in the northern zone first, but we have a thought to, expand, scale and spread it through the rest of the province. As you know, through with the recent floods and wildfires, all of that is needed. We're identifying, I think you mentioned, a community-based organization who will be a partner with us in that approach, with a hub and spoke kind of approach to care and coordination of funding and grants, and hearing from other community-based organizations what their needs are. What we've heard in our engagements so far is quite amazing. In fact, it was very clear that many folks and many community organizations know what their needs are, and they made it very clear that they not looking for health professionals to parachute in and to, take care of things, but to help build capacity with those folks who already work in the community, have the relationships with other community members, and help them, for example, with mental health first aid. I heard, people speaking about this at the federal minister meeting that you chaired, and it really was quite amazing to hear that passion and dedication, the need that people have, but also to not overlook what they already have and what they want to build on, maybe through some support and capacity development through health providers in the system. We're also awarded the contract for the needs and impact assessment. That's part of the recommendations through Davis Peer, and we're in a process of going through the information to provide them so that they can deliver that first report for 2023. I guess I would also say that all along, what we're discovering is that primary health care, public health, mental health, sexual violence, folks are already on the ground doing their regular work, our health promotion teams, and all of the community groups and organizations and volunteers and individuals that are there. So we want to be aware of that, we want to support that, and we want to fill in the gaps that they're suggesting are there. But I think the most important part is the approach, in that we have to kind of coordinate that. We have to kind of connect it. And so we're hoping that an example of an approach like a community hub model is going to help, with the spokes, help keep people connected, not duplicate, but also fill in any of the gaps that are there. We're learning a lot as we're going through this, and it's a very positive out of a tragedy, positive experience to see how much strength there is and also how much you can accomplish when you work together.
MLA Burrell, you have about 50 seconds.
Yes, well, we wouldn't want to confine any of our guests to 45 seconds, so we'll please move to our Progressive Conservative friends.
All right, we'll move on to the PC Caucus. Who would like to start? I see MLA Palmer. You've got 20 minutes.
Thank you, Mr. Chair, and a wonderful discussion this afternoon. And I think Nova Scotians, if they're tuning in, are learning a lot about how everyone works together to make sure that we're achieving better outcomes in mental health. And obviously, a system that's been stressed quite a lot over the last few years with COVID, Portapic, fires. You know, we know what's been going on, so we know the stresses on the system have been probably greater than normal. I just want to give Ms. Nichols a chance, because we've heard from a few of our panel today that data is very important. And I was wondering if Ms. Nichols, you would like to respond to my colleague across the table when, yeah, don't want to confuse the Nichols. You would had some data, national data, that you thought would be relevant to the conversation. I'd like to give you an opportunity to share some of that if you'd like.
Ms. Nichols.
Thank you very much. In preparation for this conversation, what I do know about mental health is it touches everything. The social determinants mean it's housing and food and everything. And so I wanted to make sure that, there was a clear understanding of some of the impact and the data that comes from the summer research from the Mental Health Research Canada, which is national, so I realize that. Suggests, and it reflects a lot of what we're hearing on the streets, it suggests financial concerns remain a major factor in negative mental health among Canadians, and 39% of respondents feel that economic issues are impacting their mental health. No news there. Suicide ideation among Canadians experiencing financial challenges is alarmingly high, with 41% reporting having thought about suicide in the past year. Housing and food insecurity remains high, with 23% of Canadians concerned about their ability to make rent or mortgage payments, 37% struggling to feed themselves, and 29% of Canadians cite an inability to pay as a reason for not accessing mental health care despite needing it. And that's an increase of 11% from the previous polls. I know it's national, but I think it's reflective of, kind of mirrors the sentiment that's going on here in the province. And so, yeah, I don't know if you need to hear any more, but yeah.
MLA Palmer.
No, thank you. I wanted to give you the opportunity to share some of the data, so thank you for that. So my first question will be to you, Ms. Nichols, again. And, I represent a rural constituency, so a lot of my questioning might be around that rural lens a little bit. One thing we've learned today so far, it's the preconceived notion that it's just clinical practitioners that we deal with for mental health. It's clear that this is about around the community. We are all part of the mental health system. And I've had the fortune of attending a few sessions through the Kingston Greenwood Mental Health Association that they put on. Our office deals with Project Hope on a regular basis. I just want to maybe ask you a question regarding a $400,000 commitment from the province for rural mental health, the Rural Mental Health Project. And looks to address a lot of the issues that we've been talking about. Could you expand on what supports are available in those areas with that, please?
Ms. Nichols?
So reframing that question is you're wondering what's available in rural Nova Scotia for mental health supports?
MLA Palmer.
Thank you. Specifically to funding of $400,000 to the Rural Mental Health Project.
Ms. Nichols?
Well, and any supports rural would be fine.
Ms. Nichols?
Right. You're probably referring to a number that might have been a compilation of a number of different funders, perhaps. Sure. But so we do, the majority of our work is in rural Nova Scotia. The programming is very community-based, as we've been talking about. It's based in the need in community. When we were talking about suicide prevention and intervention, We partner with a lot of organizations as well in rural Nova Scotia. So, for example, I partner with an organization called Roots of Hope, which is doing a pilot in northern Nova Scotia, and they focus on community-based education around suicide prevention and intervention. And we have met with family members, for example, who have had youth that have died by suicide in the past little while, and coming together to provide support, but also think about the system and how we can continue to support them. Additional programs would be things like our peer support programming, which exists all throughout Nova Scotia, particularly in northern Nova Scotia, where we have a number of programs that are tied to the women who are trying to control or take over their lives, and they have some agency in supporting others who are in difficult situations. We have newcomers in Southwest Nova. And so what we try and do is we try and sort of infiltrate the community, but meet them where they are. And often our programming is designed to really have those conversations and grow the programming from there.
Emily Palmer.
Thank you very much for that. I'd like to maybe address my next question to the Associate Deputy Minister Trott. I have a wonderful organization in my constituency called the Evangeline Club. And it's a great club that it's a social recreation club for vulnerable people, many with facing mental health addictions challenges, some housing challenges. And they're just a great organization, really preventing isolation and working with individuals from that perspective. So representing a rural community, not everyone has some of those organizations like that, but the government's launched some initiatives over the last couple of years regarding maybe virtual or telephone services. Can you expand on those for people in rural Nova Scotia who might not have access to a practitioner or very quickly access to those services?
ADM Trott.
Those are through the EDs, I think, and then also support for the community clinics, so part of Nova Scotia Health. But, Francine, if you want to expand on those at all. They're less for that type of community-based organization, but what I love hearing about a club like that is that's exactly what we're recognizing as being essential for community wellness. And community wellness at its roots is support for positive mental health and health and wellness. So we've been doing some interesting kind of projects with communities, culture, tourism, and heritage, because of the role that they play in community work as well. And we're really seeing where we can come together on more of these, how do we keep people well mentally and physically. So that's that piece, but maybe over to Francine for the supports in rural.
Emily Palmer.
Thank you. Specifically for the internet, virtual, or telephone services that are available, please.
Ms. Vezina.
There's so much to tell you there, because there's actually a lot of, it comes in different forms. So we fund community-based organizations who often provide services that are provincial, and they have virtual components, for example, or peer support online components or chat or whatnot. So there are things like that. There are things like Kids Help Phone, which provides services provincially and virtually. We have Mind You Well, Together All, Tranquility, Therapy Assist Online. Dana, you'd probably be better poised for providing a bit more detail in terms of what each of those are and how they differ. But again, those are available to anybody across the province. Whenever we provide the granting, and as we look at developing a community-based framework, we do look at ensuring that the distribution of supports is across the province, because we do recognize that often things can be a bit central zone based or more rich, and so we do pay a lot of attention to that. But also the Mental Health Foundation of Nova Scotia also makes a critical effort in ensuring that the distribution of their grants, and that's it's a significant amount amount of resource is also equally distributed. So depending on what you want to hear next, either Dana for detail on those programs or perhaps Starr could speak a little bit about the distribution of funds and what may be in the virtual space through their grants.
MLA Palmer?
So in the interest of time for my colleagues, maybe we'll just have one, if that's possible, and then I'll pass it on. Anyone that would like to maybe just expand on one of those services, possibly the Tranquility or anything like that that's available for those people?
Ms. Pulsifer? Ms. Pulsifer? There you go.
There. Thank you. Thank you for the question. Yeah, I can add a little bit more. Just quickly going back to the COVID time that we've gone through, we were able to, IWK and NSH, pivot very quickly using virtual means to keep seeing patients. That included our Schools Plus clinicians in the schools. Schools were closed. They still were able to make that connection. So I think that investment and ongoing in the rural and urban area, of course. So virtual care has been a really important advancement for us to use. Now, it doesn't work in all rural areas, but for those areas that it does, it has been very good, especially during that time period. And we continue to have that kind of hybrid approach, depending on what the presentation is, make sure it's safe, and also what the client is looking for. We've also been using it in our local EDs with our urgent care teams after hours, and in order to not have to be physically present, because, you know, geography-wise, we're quite a big and rural area of Nova Scotia. And I guess I would also say that during COVID and continues on, I believe we were working with receiving some funding from the Mental Health Foundation for phones and iPads to kind of help our clients actually who couldn't afford the data and the phone package to actually stay in touch with us. And that's been a really well-resourced strategy or approach. Not sure if that answers it.
MLA Palmer.
Yeah, thank you very much. I appreciate all of you being here today. I'll pass it over to my colleague, MLA Smith.
MLA Smith.
Thank you very much, Mr. Chair. And just to echo some of my colleagues' comments, thank you very much for the work that you do and the work that your teams do to help Nova Scotians. The topic today is implementation of additional supports for mental health and addictions. And I'm a guy who likes to stick on topic. So I have two questions. They're both going to ADM Trott. And the first one's going to be about mental health, and the second one's going to be about addictions. So this morning, Minister Comer was involved in an announcement at Dalhousie. I believe it was the Dalhousie Centre for Psychological Health. I'm wondering if you can share a little bit about this initiative and how it differs from other supports in the province.
ADM Trott.
Yeah, great. Thanks for the question. We're very excited about this initiative and its potential, because what we're doing is providing an opportunity for psychology students to actually get training as part of their program under the supervision of clinicians. And the clinic is focused on serving those from underrepresented communities and those, really who have a hard time getting supports because they can't afford to go to a private practitioner. So it's really creating an opportunity to test a clinic. We're doing service code testing there that will help us as part of our mandate around introducing codes to have more clinicians from the private sector participate in providing services. So there's a bit of testing happening there, but super excited. Dal really came to the table in a way that was different for us and just saw the opportunity to play a role in helping to contribute to not only increasing services, because they're going to be actually serving people in the community, which is amazing, but kind of helping us also to determine some of these pieces that we're trying to figure out as we move towards some of these other mandate items around service codes. Yeah.
MLA Smith, you have just under 6 minutes.
Thank you. Like I said, I have one more question for you, ADM Trott, and it relates to the addiction side of things. Most of the conversation today has been about mental health, but you folks are doing important work with addictions as well. Specifically, during the research, we talked a little bit internally about the recovery support centers. I'm wondering if you can share what those initiatives are and how they're being helpful to Nova Scotians.
ADM Trott.
I will get at one point. I'll probably have Dana jump in here with some more details, but I think it's a very good point, and we always in the office, it's why the office name changed to Addictions and Mental Health, to make sure that that profile is happening there, because we're finding, in complex cases, there can be mental health and addictions, and so you're really trying to treat both of those, and so it's important to be in community to do this, and so that's where the recovery support centers and that new model has come into play, because they're really working in communities, and their walk-in service, they have programming that goes on there, but I'll ask Dana to speak more about what happens at those centers.
Ms. Pulsifer?
Thank you for the question. Yes, there's a lot of renewed focus on the addictions part of the mental health and addictions program of care. Recovery support centers are just one of them, and I can give you a bit of information about that. We also are really starting to emphasize more on concurrent disorders, such as folks who present with both, and you really can't separate that out. And so I think that's something that is really important for us to think about, and how we're advancing capacity for our clinicians. We have psychiatry with some expertise in that area, and so we're doing a lot of training and developing kind of a framework to help ensure that we can offer both of those things simultaneously when that's required. As far as recovery support centers, we've, I think there's 10 overall, 4 to 6, I always get this mixed up, are existing and changing over to the new model of care that's been in place for the last couple of years. I can just tell you that in the Central Zone, Dartmouth was opened in January of 2022. New Glasgow was opened in February of 2022. Middleton was an existing and moved to the new model of care in August of 2022. And Lunenburg, same, was an existing center, but moved to the model in November of 2022. The additional recovery support centers that are scheduled to open in the Eastern Zone would be North Sydney, another one in Sydney. That's within the next, actually October for North Sydney, and within the next year for Sydney. And then a realigned recovery support center in Strait Richmond. We're hoping no later than March of 2024. In Northern Zone, we have a new one in Truro to open, we're hoping December of 2023. And Amherst within the next year. And Central Zone has a new one in Halifax opening within the next year, no later than March 2024. Hoping I'm not missing any. And I think, they're all providing that continuum of care with withdrawal management, face-to-face or sometimes online assessment to properly match their needs. They can call our intake line, like for any other presenting issue, or they can actually call the local recovery support centers directly, and we also have walk-in that can happen. So, and like with every other service in our program area, we really kind of base the needs of that individual to the type of service or support that they require. And when we think about the whole kind of continuum of care for addiction work, again, we're looking at partnering with our AA and our Sept stepped programs right up to inpatient withdrawal management. So really trying to make sure that we have our hands and access and navigate to all of those levels of care, which we don't all provide ourselves, but we partner with them in those areas. Just
No, go ahead, sorry.
can I just quickly add, we're pretty pleased. Dr. Dave Martel is our provincial leader for addiction medicine, and I was getting an update from him on the recruitment for addiction medicine physicians. And so we've really been focusing our energies as well in the physician field for addiction medicine. There's not a lot of folks out there with that training and interest, and we have 8.2 FTEs, and I'm really pleased to say that we've hired 2 FTEs already, which are 3 physicians in the central zone. They're doing interviews for 4 other physicians.
The time for the PC caucus questioning is expired. We have 8 minutes for each caucus to do another round. So I'll begin with the Liberal caucus. I see MLA Clark. You may begin.
Thank you, Mr. Chair. And obviously, one of the big challenges in terms of achieving universal mental health will, of course, be having the people to give the care, right? The professionals across the board. So a question for, I believe, Ms. Brennan and Ms. Pulsifer. One of the things that we hear about from time to time is issues with HR and recruitment. So I'm just wondering right now, do you have the latest data in terms of what vacancies look like for psychiatrists, at NSH and at IWK? Thank you.
Ms. Brennan? Oh, sorry, Ms. Brennan. Thank you. Go ahead.
Thank you for the question. Recruitment is critical to mental health and addictions. In medicine, we have our MRIs. In mental health and addictions, our equipment is our people. And so ensuring that we're looking at recruitment and retention of our people is a critical area for mental health and addictions. I can tell you that right now within the IWK, we've reduced our vacancy rate down to 1% for clinical positions, and we've done this through various recruitment and initiatives to engage national psychologists to come into our program. What we've hired 4 in the last 3 months, PhD psychologists, and continue to do various levels of recruitment. The other component that we look at when we're thinking about our human resources is to look at how can we optimize the scope of practice for those clinicians and physicians to stick to that high level end of work, and what other roles can we introduce, and can we create a team so that those needs can be met by various roles. So identifying what new roles can do clinical work. So we've also introduced a suite of a new allied health roles, additional occupational therapists, additional recreation therapists, board certified behavioral technicians to actually support, because we recognize there's an increase in complexity. So through those efforts, we're actually able to protect people to stay at the higher end of the scope, and then bolster more FTEs through our clinical services. That's one example of a recruitment effort, and so I'm very happy. And right now, within our Department of Psychiatry, we have 1 FTE within the IWK that is a vacant, and we're in active recruitment in interviews at this time.
And Ms. Pulsifer? Ms. Pulsifer. Yeah.
Thank you. Excuse me. So the question is about recruitment initiatives for psychiatry, or generally in clinical positions?
Emily Clark.
Generally, but specifically, I did also ask how many vacancies there are currently for psychiatry. Yeah.
Ms. Pulsifer.
Thank you. So our general clinical roles, I just had an update. We've gone, so our social workers, clinical social workers, psychology, OT, those who provide clinical care, our percentage of vacancy was 20.3 in July of 22. And unfortunately, it is increased to 22.3% just this past July. So we continue to struggle in that area. And I think, like Ms. Brennan mentioned, we've have many strategies and approaches underway to try to alleviate that gap in positions. And one of those are, as she mentioned, using all clinicians, including psychiatry's role, to top of scope of practice, meaning that there are other allied health professionals that can provide support and care, and our Bachelor of Social Work group can run groups and other supportive means that kind of, I guess, help leverage what we have. So despite an ongoing vacancy rate, we have been able to kind of pool those types of positions to continue to provide the care that we need to provide in a high quality way. Vacancies for psychiatry, we've actually done some really great recruitment in the last year plus. But we do have a few outstanding vacancies. So in Central Zone, there's 1.8 FTEs still to fill. I think they're actively being recruited, however. Eastern Zone, I'm really pleased to say we have 0 vacancy. There's no FTEs to fill, and I think that's for the kind of congratulations of the department head in that zone, and all of the recruitment efforts, and really kind of selling the Cape Breton experience. And we're hearing some great things coming out of Cape Breton and those inpatient units. Northern Zone continues to have a vacancy of 6 FTEs, 5 are adult and 1 is child. Although I do believe there's some recruitment processes happening right now. So a lot of them, it takes a bit of time to recruit and onboard even when you have interested candidates. So I'm just giving you kind of the general numbers. And Western Zone, there's 1.2 FTE. Again, we do a really good job of trying to provide that care across the Western Zone. There is some virtual care that happens with psychiatry as well to try to fill in some of those gaps. I did want to mention the Dallas Psychiatry Residence Program. Second-year residents do a rotation in Eastern Zone at the inpatient units. I think that's been a real positive, and trying to keep our own within Nova Scotia. And yeah, really great recruitment area for us.
MLA Clark, you have a minute and a half.
Okay. Thank you, Mr. Chair. So as you mentioned, Ms. Pulsifer, the vacancy rate has increased by a little bit, but has increased in the last year or so. So a little more than 1 in 5 of these positions are vacant at this point. Why is it going, I guess, in the wrong direction, I would say? I'm sure there's lots of work underway, but what is the biggest challenge, I guess, in terms of filling those positions and getting that number, moving back down in the opposite direction to where it is now?
Ms. Pulsifer or ADM Trott?
Whoever can answer it.
Yeah. ADM Trott? Yeah.
Sure. Well, I guess not unlike every other jurisdiction, we are having real challenges in recruitment. And so we are doing some things in addition around working with our colleges and universities to try to expand seats, but they're longer term solutions for sure. So it's absolutely a challenge. We're up against our colleagues in the country and our colleagues internationally, but we are working on a strategy that we hope will help us really narrow in on what we need from a needs-based planning perspective. And as you've heard folks say, looking at the scope of practice.
The time has expired for the Liberal Caucus. MLA Burrow, the NDP Caucus, you have 8 minutes.
Great, thanks. Ms. Nichols, I wanted to ask you a couple of questions about how some things look from the point of view of the CMHA world. I'd like to go back to the numbers you were talking about earlier about people's connecting financial struggle with mental health issues. So we know there's a lot of people living in the space of this connection. I wonder if you could comment on some of the real impacts as you see them and the people you serve of the housing crisis and the affordability crisis on the mental health of the people that the CMHA is in touch with?
Ms. Nichols?
Thank you for that question. As I think we all agree that housing is a social determinant of our health, and those who are living unhoused or at the risk of being unhoused are living with, if not mental illness, they're on the continuum, and they're moving up towards crises. And so every day, our folks that work on the ground, in particular with Project Hope, are meeting people who have stories, and the things that they're noticing are, it's not just, it's everybody now. It's the elderly, it's the people. Last year we were dealing with a pregnant mother who we had to provide a tent with, in community, and so there are no barriers to having to experience this sort of thing in community. So mental health is absolutely impacted by virtue of the challenges that people receive, and so the work that we do really addresses not just the housing piece, but also the piece around providing them the supports and the resources to manage their mental health as well. And that, it's also tied to so many other elements along that continuum. It's around eating well and finding a connection within community. It's around having access to food. And so those are some of the supports that we also provide when required, depending on the situation.
MLA Burrow?
Thanks. I also wanted to ask about the impact on the people that you serve of long wait times. So we know that wait times vary a lot across the province, particularly for non-urgent care. In some parts of the province, Colchester County, it's pretty nearly a year. Can you comment on the impact of on the people that you serve of longer wait times particularly for non-urgent care?
Ms. Nichols?
Thank you. So to be clear, we're not clinical, and so the type of support we provide is really community-based. So when we're meeting with folks that are dealing with their challenges, the pillars that I spoke of are education and navigation. And so a piece of what we would do would be to help them navigate the system to find maybe the right door into support for them. So there may be a wait time, but there may be supports that are available in the short term that will help bridge them to get to where they need to get to, or it may be the solution for all we know. So I think that there is tremendous opportunity to leverage a lot of these resources that are in community that will help mitigate the impact of the wait times along the way. And I think that's where the work needs to be done as well, frankly.
MLA Burrow?
I wanted to ask of the office and the department about yesterday's announcement, about the wait lists for spectrum and ADHD people. With that $500,000 pilot, in the way it works, what incentive is there for the private practices, which are already, we know, loaded up? What incentive is there for them to take on those who will now have funding for services through this program, rather than the paying customers they already have? How does it work?
ADM Trott?
Yeah, and maybe I'll ask Francine to jump in here, but it's a pilot, so we are exploring kind of that very question, actually. And so we've been working with the association to determine the best approach on how to engage the private psychologists and see, what will entice them to be part of this. And I think, there's a an understanding out there with private clinicians of the challenges of the wait lists and a desire to contribute and a desire to be part of a solution. And so we are seeing an excitement in just these, these early conversations as we're forming the pilot. So we're not sure how many will kind of sign up and be part of the pilot. We're really hopeful though, because it's a very for this particular challenge, like the assessments for autism and ADHD, the wait list is significant. And not every psychologist can do that work. It's very specialized. And so to be able to tap in more broadly to the private sector to bring to bear what they can, I think to drive this wait list down will be very helpful, but also we'll be testing kind of the service code. So how do we engage with private practitioners going forward? Not unlike what we do already in the health system with dentists and optometrists and there's doctors. It's how we pay for service, but this is a new area because of how this system has been created over time.
MLA Burrow, a minute and 30 seconds.
Yeah. So the announcement spoke of a wait list of 1,700 people. So the pilot envisions what kind of change in that?
ADM Trott.
Sorry. So in part is to test service codes, like for our mandate around how do we create a system to bring private practitioners in and compensate. But we've got this wait list sitting there. It's a perfect opportunity to take a service that we know it's a specialized service that only specially trained psychologists can do. So let's test the billing codes, but like actually bring folks into the system to help us solve a problem. Yeah.
MLA Burrow, 30 seconds.
Yes, the budget talked about $500,000 study to explore universal mental health care. Has the contract been let?
What's this one? Sorry.
There's a study in the current budget had $500,000 provided to study universal mental health care, and I'm wondering, is this in the form of a contract, and is there anything more about the contract we should know?
ADM Trott.
Francine Vezina is going to respond.
Ms. Vezina?
Yeah.
There's a couple, so I'm not quite sure which one that is, but
Order. The time for the NDP Caucus has expired. We will move on to the PC Caucus. I see MLA Taggart has his hand up. You have 8 minutes.
Thank you, Chair. And before I start, just a couple comments, if you don't mind. I really want to thank you all for the work you do in what's a real challenge across Nova Scotia and across Canada, I think probably the world. I don't know, but I really appreciate the job you do and the passion you've shown here today, the understandings that you've shown here today. So I just want to, so very glad to hear so much talk about community today, and Trott will know where I'm going with this right off, I think. But anyway, I know from experience how hard it is and has been to get folks to come out and say, hey, I need help, I need to see a clinician. And I really believe that the place to start on recovery, or where we need to go with mental health, is start right in the community. And I think my community there in West Colchester, that's, it certainly has some challenges over the last, because of the tragedy, and what they've done, okay, in that community to sort of what I'll call revitalize it and become a community again. And I just think that I strongly believe that that is where we need to go to sort of get a handle on this whole mental health situation, is start in the community and let people build pride in their community and pride in themselves. Now, I have some questions. I just had to say that, but I'm going to skip my question. Johnny has a really good question he wants to ask, and if there's time, I'll come back. Okay, but I just had to say that. Thank you all very much.
MLA White.
Thank you, Chair. Thank you, Tom. So as a struggling PTSD victim and a current mental health professional, kind of both sides, I really want to thank you guys for coming in, all the work you're doing, and to hear you speak about not parachuting into a community and repairing and leave and go. Because as Tom is alluding to, communities go through traumatic events, and they build resiliency, and it is post-traumatic growth, which is what we need. And although you guys didn't mention PTG, it is an actual thing that his community is going through right now. I said that because I didn't want to leave Emily Nichols over there talking about the only one with a mental health issue here, so I wanted to make sure she had company. But anyway, I wanted to tell you about the second day clinic in Cape Breton. As a counselor and as somebody who traveled that road myself, I know that when my psychiatrist was trying to work with me, I was fighting with him because everything we do is how we make sense of our current events. Everything I did yesterday is how I make sense of today. It continues day by day, minute by minute. And when I was into the struggles of PTSD and depression, I wasn't making sense of a lot, and my self-talk was really bad, and I still challenge with that today. But anyway, when I think of this day clinic, I think of that as the opportunity to teach strategies and have them go home and try them and then catch it right away. Am I right on that? That's kind of what I want to know from you. I want to know what the capacity of that clinic is and just what's being done there, if anybody can help with that. And I'll leave it to Tom after that. Thank you.
Ms. Pulsifer? Thank you.
Thank you. You're talking about the day hospital? Yes. Yeah, absolutely opportunity. And as you know, the day hospital in Sydney just opened, yeah, late July. Great. And so far, there's been about 19 distinct individuals and around 218 visits, so they're slowly kind of getting their feet under them. But all kinds of great work and potential great work that can come out of that that approach or that model of care. And as you know, day hospital is twofold or more. So folks who are, you know, could be discharged from the inpatient unit who are stable enough, they have, you know, good home environment to help support, but maybe have additional work to do, that they can step down into the day hospital setting, which provides that intensive, but kind of coping and helping you live, you know, well in your community. Or we have clients and patients who may be receiving treatment and support in our outpatient clinics, but things are escalating and they need something more intense. So that's the other kind of avenue or route that day hospital is intended for. The types of programming that happens there, we have pharmacy care, we have OT as part of the team, there's recreational therapy, there's your typical psychiatric you know, assessment and medication and treatment protocols, social work and psychology. And I think depending on what the individual's presentation is or diagnosis, that's what kind of would dictate on how the care plan, treatment plan, as well as education and supports and services, all geared to that person's unique kind of presentation. So, yeah.
MLA White? Oh, sorry, MLA Taggart.
Thank you. I'm not sure who to ask the question to, but is there plans, what plans might you have to expand these mental health day hospitals? I love the idea. Is there plans to go further with that?
Ms. Pulsifer.
Thank you. Yes, we do. We have plans to expand into northern zone as well as western zone. We're hoping within the next year, as with many things right now, you know, location of space and our HHR challenges, you know, keep us moving and hopping along. But we have had a few delays, but we're in the middle of finding other kind of strategies and approaches to be able to do that. So we're hopeful to do that within the next year.
MLA Taggart, you got a minute and 20 seconds.
Oh, gracious, we're quick. So, well, thank you. So if I could to CMHA and FNS. Sorry. Before I was elected, I served in multiple organizations in my community which were mental health focused, and I can say from personal experience at that time, funding was very difficult to find. And recent investments around this province, I know, will serve many communities in providing this resource. I guess ADM Trott referenced community-based organizations, and in your future, in your work, or as you look ahead, what do you folks see or where you value most? What community-based organizations moving forward, or what type of role might you play in that? Whichever would prefer to speak to it.
Ms. Cunningham.
Thank you for the question. I think the role that the Mental Health Foundation of Nova Scotia would play is to raise the funding to let the people who are on the ground in their communities do the work that they know needs to be done. So our job there is to raise more money and to do it in a very timely fashion to get the money to work as quickly as possible in our communities.
Ms. Nichols, the time has expired. Sorry. And again, thank you for all the questions from the committee. It's an opportunity now for witnesses to have, I guess, a closing remarks. And so is there anybody that would have? Oh, I see Ms. Nichols has her hand up.
Just a moment.
Oh.
Thank you for your patience. I know that we've spoken a lot today about our mental health system in Nova Scotia, and I'd like to take just a few moments to end this conversation about the system that supports the system as well, the system that's within it. At CMHA Nova Scotia, we're collaborators at heart. And we all are, actually, and I know that for a fact. The impact sector of over 6,000 organizations across the province pride themselves at being collaborative, but we're not always coordinated. So I really think that the opportunity is really understanding the capacity that we can hold to support the full system. Additionally, we believe in order to build a healthy community impact sector to serve the needs of the province, it's important to consider the needs of the sector. So many community-based organizations work with and hire people who are facing significant barriers themselves. In order to implement the additional mental health supports from community-based organizations that we've been speaking of, we need to continue to look for ways to invest in the core and operational funding, which includes that we have enough resources to ensure people have a living wage, supportive accommodations, and a reasonable quality of life in their work. Without this, it will lead to further burnout and harm, and likely make the crisis even worse by causing the helpers to have less capacity to help. So I'm just asking you to think a little more beyond kind of the services we're providing the community, but the people that are providing the service for the community, because if that doesn't work, then the rest won't work. My background is in business, and I can safely say that running a nonprofit is way more complicated than running a comparable sized business. When the for-profit entity finds a way to create value for a customer, it has found its source of revenue. Who's the buyer, right? When a nonprofit finds a way to create value for the beneficiary, providing community-based mental health support in our case, it has not identified its economic engine to support that. The beneficiary cannot cover the cost of the service. We must find the funds to provide the service through other means, which is a separate additional step. Achieving sustainability in the nonprofit funding model is therefore critical for the delivery of the social safety net of the valued programs and services that are not covered by other pillars in our society. Traditional funding models allocate money to specific projects, constraining sometimes how the money is spent. And it sometimes leaves a little bit of difficulty for the flexibility in how we serve the community. So other ways that which means that sometimes we're just surviving, because the core funding is not really addressing our operational needs. And so some of the ways that we would suggest in addressing the systemic challenges would be to increase the funding cycles. There's simple solutions that maybe we need to reconsider as well in order to support the overall system. At CMHA, we're keen to work with the government, our sister organizations, and all our other funders, and most importantly, our communities, to ensure that we have mental health for all. And so I really thank everyone in the room for the opportunity today, as well as the people that are sitting with me at this table. So thank you.
Thank you, Ms. Nichols. Are there any other closing remarks? Ms. Cunningham.
Thank you very much. Our tagline at the Mental Health Foundation is changing the way people think. And I believe that that's what we're all working toward here at the table, changing the way people think about their own mental wellness, the recovery through mental illness and addiction, and what it means to be part of a community. We have great data at our fingertips because every application we receive for a community grant identifies the needs in a community. So they're telling us what are the gaps, what pieces are missing, what do they need help with. And what we've done is we've looked over all of our applications over the last 12 months, and we've identified 6 priority areas, and I don't think there'll be a surprise for anyone here: diverse communities, vulnerable populations, addictions, youth, suicide prevention, and mental health literacy. And I just wanted to end my comments today by talking about mental health literacy. There is a huge appetite among Nova Scotians to learn more. And I believe we are in a position where we can help Nova Scotians understand what it means to triage mental health, to understand when they do need to see that psychiatrist or when they can go to a student youth center in their school. There are so many programs out there. Safe Talk and Assist were mentioned, mental health first aid, mental health and wellness in the workplace. We've seen an increase in people asking for that information, so let's work to give it to them. Let's educate Nova Scotians and help them not just navigate the system, but navigate their own mental health and their family's mental health, their teammates, their colleagues, their neighbors, their children. Let's give them the information they need. It's not awareness anymore. We're all aware. We're all aware there is a serious problem. It's about educating now. It's time to put some meat on the bones.
Thank you, Ms. Cunningham. ADM Trott, sorry.
I won't keep us, but I just really wanted to say thank you. This really was a great opportunity for us to share the big pieces of work that we're working on, and I'm so proud of how far we've come and how we're working together as a team across system and in partnership. And we've got a lot left to do, but I think that we're really proud about where we are right now and the important role that is ahead around how community-based organizations work in partnership with us across the system to create that much stronger system to deliver care. So, thank you.
Thank you, ADM Trott. And on behalf of the committee, thank you to our witnesses for being here today. This concludes our question and answer period. We're going to take a short 2-minute recess to allow our witnesses to leave, and then we're going to get back to, we have at least one item on committee business. So 2 minutes. Thank you, members. And we're going to get into committee business. And on committee business, we had one item, some correspondence both on August 6th and August 16th, emails from Matt Casey re the Nova Scotia Health using dirty surgical instruments on patients. These were forwarded to members when they were received and again yesterday. So is there any discussion? MLA Palmer.
Thanks, Mr. Chair. So this side of the table, we believe it's important to recognize Mr. Casey's concerns and his correspondence. So I'd like to move that the Standing Committee on Health write a letter through you, Mr. Chair, to the Department of Health and Wellness requesting an update on the concerns outlined in the correspondence from Matthew Casey.
Thank you, MLA Palmer. Do we have any discussion on that item? Hearing none. I'm going to ask for a vote. Is all in favor of sending a letter to the department asking for an update on that? All in favor say aye. Aye. All opposed? Okay, motion is carried. Is there any other business from committee members here today? Seeing none. Our next meeting is scheduled for Thursday, October 19th. From 9 to 11, as we've all been informed. I think the House will be sitting at that time. Mental health, the topic will be mental health supports for First Nations communities. Witnesses will include Tajik Gemik, Mi'kmaq Health and Wellness, Mi'kmaq of Nova Scotia Health Directors Committee, Nova Scotia Health, IWK Health, Office of Addictions and Mental Health. So with that, I would ask, I will say we'll conclude business today. The meeting is adjourned.